How does furosemide lower blood pressure? Amlodipine relaxes your artery walls to lower blood pressure. Furosemide does something completely different. It goes to your kidney and it makes your body throw out water. If that sounds too simple, I promise the science underneath it is not. Because to understand how furosemide lowers blood pressure, you first need to understand one tiny section of a tube inside your kidney called the loop of Henle. And once you understand that, everything clicks. Let us go. Furosemide, brand name Lasix, probably the most recognized diuretic in the world. It is on the World Health Organization's essential medicines list, which means it is considered one of the medications every health system on Earth should have available. It belongs to a class called loop diuretics, named after the specific part of the kidney where they act. You swallow a 40 milligram tablet. About 60% of it is absorbed from the gut into the bloodstream. And here is something unusual about furosemide. Once it is in the blood, 95% of it binds tightly to albumin, the main protein in plasma. That means it is not filtered by the kidney the way most drugs are. The glomerulus, the kidney's filtration unit, cannot pull furosemide out of the blood because the albumin molecules it is attached to are too large to cross the filter. Instead, the kidney has to actively secrete furosemide directly into the urine. Special transporters in the proximal tubule, called organic anion transporters, grab furosemide from the blood and inject it into the tubular fluid. And that is exactly where it wants to be, because its target is not in the blood. Its target is inside the kidney tubule, specifically in one section called the thick ascending limb of the loop of Henle. Before we get to the mechanism, let me give you the 30-second kidney tour. Because without this, the rest will not make sense. Your kidneys filter your entire blood volume, about 180 liters of fluid every single day. But you only produce about 1.5 liters of urine. What happens to the other 178.5 liters? It is reabsorbed. Your kidneys filter everything out of the blood and then selectively take back what the body wants to keep: glucose, amino acids, water, sodium, potassium, chloride, leaving behind waste products to become urine. The filtering happens in the glomerulus, a tiny ball of capillaries at the top of each nephron. The filtered fluid then flows through a long, winding tube, the proximal tubule, then the descending limb of the loop of Henle, then the hairpin bend at the bottom, then the thick ascending limb back up, then the distal tubule, then the collecting duct, and out as urine. Most of the sodium and water reabsorption happens along this tube, and the single most important reabsorption site in the whole kidney, the site that handles 25% of all sodium reabsorption in the body, is the thick ascending limb of the loop of Henle. That is where furosemide goes. That is where everything changes. On the surface of the cells, lining the thick ascending limb, there is a protein transporter called NKCC2. The name stands for sodium potassium 2 chloride cotransporter. It is a molecular pump that grabs one sodium ion, one potassium ion, and 2 chloride ions from the tubular fluid and pulls them all back into the kidney cell and from there back into the blood. This transporter is working constantly, pulling sodium back out of the urine and into the bloodstream. And because water follows sodium, osmotically, water is also pulled back. This is how the kidney reabsorbs the vast majority of the fluid it filters. Now, furosemide arrives at the NKCC2 transporter. It binds directly to the NKCC2 transporter and blocks it completely. Sodium, potassium, and chloride can no longer be reabsorbed. They are stuck in the tubular fluid, and because those ions are now sitting in the tubule, increasing the osmolarity of the urine, water is osmotically dragged into the tubule from the surrounding tissue. More water in the tubule, more sodium in the tubule, less of both being returned to the blood. The result is a dramatic increase in urine output. Furosemide can cause a patient to produce 2 to 3 liters of urine within a few hours of a single dose. This is why the nickname for furosemide among clinicians is sometimes the water tablet, though that undersells enormously what it is actually doing at molecular level. Now let us follow the domino effect all the way to the blood pressure reading. Domino 1, NKCC2 is blocked. Sodium and water stay in the tubule. Domino 2, urine output increases dramatically. The body is losing fluid. Domino 3, blood volume falls. There is now less total fluid in the circulatory system. The blood vessels are not as full. Domino 4, cardiac preload decreases. Preload is the amount of blood returning to the heart to be pumped out. Less blood volume means less blood returning. The heart fills less with each beat. Domino 5, cardiac output falls. The heart pumps less blood per minute, and because blood pressure is directly proportional to how hard the heart pumps and how much resistance it meets, less output, lower pressure. Systolic pressure falls, diastolic pressure falls. Furosemide also has a secondary vasodilatory effect. It causes blood vessels to relax slightly, which contributes to the pressure reduction beyond just the volume effect. But the primary mechanism is simple and elegant. Drain the volume, lower the pressure. This is also why furosemide is the first-line treatment for acute pulmonary edema, the emergency where fluid floods into the lungs, causing severe breathlessness. Furosemide starts working intravenously within 5 minutes, pulling fluid out of the lungs and into the urine. It is one of the most dramatic and life-saving drug responses in clinical medicine. In the last episode, we followed amlodipine, which lowers blood pressure by relaxing artery walls, blocking calcium channels in the smooth muscle cells. Furosemide uses a completely different route to reach the same destination. Amlodipine reduces the resistance the heart pumps against. It widens the pipes. Furosemide reduces the volume of fluid the heart has to pump. It drains the tank. Both lower blood pressure, but through entirely different mechanisms. This is exactly why they are often prescribed together. They complement each other perfectly. Amlodipine relaxes the vessels. Furosemide reduces the fluid load. Together, the blood pressure reduction is greater than either alone. 3-drug combination for resistant hypertension often includes an ACE inhibitor or ARB, a third mechanism, alongside these two. But that is a subject for another episode. Because furosemide pulls so much sodium and water out of the body, it also inevitably pulls out other electrolytes. And this is where the side effects become clinically important. First, hypokalemia, low potassium. The NKCC2 transporter normally pulls potassium back into the blood. Block it with furosemide, and potassium is also lost in the urine. Low potassium is dangerous. It causes muscle weakness, cramps, and most critically, it makes the heart electrically unstable. It can trigger arrhythmias, irregular heartbeats. This is why patients on furosemide often take a potassium supplement or are prescribed a potassium-sparing diuretic alongside it. Second, dehydration and low blood pressure. Furosemide can work too well. Overdiuresis leads to low blood pressure, dizziness when standing, called orthostatic hypotension, and in elderly patients, an increased risk of falls. The dose must be carefully calibrated. Third, hyponatremia, excess sodium loss leads to low blood sodium. Symptoms, confusion, nausea, headache, in severe cases seizures. Fourth, ototoxicity. At very high intravenous doses, particularly in patients with kidney failure, Furosemide can damage the cochlea, causing hearing loss or tinnitus. This is rare at standard doses, but important to know. Fifth, gout. By competing with uric acid for the same renal secretion transporters, furosemide can raise uric acid levels and trigger a gout attack in susceptible patients. This is why furosemide is a prescription medicine. Its power and its risks both require medical supervision and regular monitoring of blood electrolytes. 3 things to take away. 1. Furosemide lowers blood pressure by blocking the NKCC2 transporter in the loop of Henle. Sodium and water are not reabsorbed. They leave in the urine. Blood volume falls, cardiac output falls, pressure drops. 2. It works by a completely different mechanism from amlodipine. One empties the tank, the other widens the pipes. Together they are more powerful than either alone. 3. Furosemide is powerful, but not without risk. Potassium monitoring is essential. Dehydration must be watched for. Any dizziness on standing, muscle cramps, or change in hearing while on furosemide, tell your doctor immediately. 1 tablet, 1 kidney, 1 transporter, and a domino chain that ends with a healthier blood pressure. If this episode made you understand your prescription a little better, share it with someone who takes a water tablet and has never been told how it actually works. Subscribe for more. Next week, we go inside the immune system to explain how a vaccine trains your body to fight disease. Questions below. I read everyone. Stay curious, stay well. See you next week. These contents are developed and authorized by registered pharmacist Darius IV and by Doctors Academy, an initiative of
Ireve Biotech,
the home of doctors' products.